Well, good afternoon and welcome to IMSH, Adam and the organizing committee. It's really a great pleasure and a great honor and really humbling to be here to talk to you about my passion, resuscitating resuscitation. And what I would like to talk to you about today is really how embedding simulation research into practice is tough without getting lost in translation. I do have some potential or perceived conflicts with grants in resuscitation, cardiopulmonary bypass, glucose control, and simulation, but none of the items that I'll show you in any of the photos are intended to endorse any specific product or technique, but simply to be examples of things that we have encountered along the way. When we talk about translation, I think the recent publications by McGahey and following the Erickson sort of paradigm have really started to shine through. And when we talk about translation, we talk about T1, or how our training affects performance on mannequins, and then T2, where we start to translate that and see how our training on mannequins starts to be measured on operational performance, on real patients and individual outcomes. And when we get really to the next level, we start the T3 translation, which means that we have actually meant that when we train on mannequins and are competent or excellent on mannequins, that's translated into practice on patients. And then patient outcomes are measured and improved, that we've actually gone through the cycle and made a real difference. And when we do that efficiently and effectively, we get to the holy grail of T-value, or the ultimate translation. And so throughout the talk, I want you to walk through with me the process from when resuscitation was reborn in the 1950s up until now, and the progress we are making as an example of the translational process and how we can embed research into outcomes. Now, if we want to think about it a little more simply, when we think about simulation-based education, we can think about the scope of care, how we affect self-efficacy or self-confidence, the next level, competence on mannequins and on patients, and the operational performance of teams delivering better process of care that results in effective care and improvement in patient outcome. Perhaps if we go back and think about the rebirth of resuscitation and resuscitation education and implementation, it really goes back to Asmund Lerdahl, Peter Safar, Bjorn Lind, who recognized that although we knew many facts about the physiology of resuscitation and CPR, that until we had training systems and training mannequins that worked, that we would not be able to get that message out and we would not be able to effect change. In fact, Jude Cohenhoven and Knickerbocker in 1961, more than 50 years ago, knew and demonstrated in their publication that it was important to generate very good blood pressures, diastolic blood pressures, in order to achieve resuscitation. Here are some of the original tracings from those patients under anesthesia. And Peter Safar, who you see pictured here, can be seen ventilating a patient in the 1950s, rediscovering that ventilation was necessary, and his mannequin were anesthetized and paralyzed medical students. Here he is delivering mouth-to-mouth exhaled breath ventilation and demonstrating that when the airway obstructs, ventilation is not accomplished.
By supporting head and jaw. He can determine the adequacy of ventilation by watching the chest movements, by feeling the inflation, and by hearing exhalation. Second, inflation pressures are adequate and can be adapted to the resistance.
That mannequin grew up to be the chief of medicine at Mass General Hospital. But Asmund Lerdahl here developed a mannequin that could then be used to practice that technique and to teach that technique. And you can see the similarities in the way that the human body and the mannequin were developed in order to facilitate that training, the few simple things that were needed in order to mimic the real state. For many, many years here in 1906, Kreil and Dali knew that the basic problem in resuscitation was to better secure, by means of some infusion, in that case epinephrine, a coronary perfusion amounting to from 30 to 40 millimeters of mercury. This was more than 100 years ago. So 50 years ago, when CPR was reborn, between 50 years and 25 years ago, in 1988, I graduated from my residency. And at that time, there was no organized registry or evaluation of resuscitation science, the science of education and implementation, and guidelines were really experts sitting in a smoke-filled room, coming up together with what they thought was best. In 1990, they collected and came to consensus at the Utstein Abbey to develop a real nomenclature and outcome reporting template for cardiac arrest studies that allowed them to start to compare outcomes. And with this template, we were then able to start collect data uniformly so that we could then discuss the outcomes across centers. And we could also entice journals to start requiring publication with specific guidelines on nomenclature and outcome targets. And that publication, I think, really crystallized the coming together of the field. Now, in 1988, there were no pediatric advanced life support courses. The American Heart Association and my mentor at Children's Hospital was Arno Zaritsky, who had participated in developing the first PALS course from the American Heart Association. In that course, there were about 16 hours of content, of which 8 hours were lecture, like this. And of the skills station, 80% of the time was the instructor demonstrating without the student practicing. The tools they had were mostly paper and textbook, and not mannequin and not interactive. There was no team training. It was all about content and bicarbonate and calcium and the theory of resuscitation. It was a great course. It was a great step forward, but it did not accomplish the improved resuscitation of children in a great manner. Through those years that followed, with the collection of data, the evolution of courses, and the integration of mannequins and simulation and skill trainers into the course, more than 280,000 individuals are now trained in the pediatric advanced life support courses across the world. And it now implements the latest guidelines by consensus that are published every 5 years. But consistently in studies of CPR outcomes and resuscitation outcomes, it's consistent that what we know that's published today is only partially translated into our guidelines and medical standards, and only about half of that is what we teach, learn, and remember. And when we measure and videotape what we do at the bedside, it turns out that our survival outcomes are reduced to about 20%. And so we perhaps have miles to go. This slide, in the black, all of the black columns are analysis of real resuscitations, more than 200,000 resuscitations reported to the National Registry of CPR, Get With the Guidelines Resuscitation. The black bars represent when no deviation from resuscitation guidelines are reported. The gray survival outcomes are all for return of spontaneous circulation, 24-hour survival, or survival to hospital discharge when resuscitation deviations or errors are made. The gray columns are all lower than the black columns, meaning that we frequently make mistakes during real resuscitations, and the consequences of that is that patients die. We now know that our mechanism of getting the word out, that it takes more than 2.5 years to go from a guidelines release to implementation at the bedside. If you think about hypothermia, if you think about quality CPR, if you think about all of the things that are emphasized in our current guidelines, until they really hit the bedside and are embraced and used is usually more than 2.5 years. Our single-center studies, as they go through multi-center trials, multi-center applications for efficacy, effectiveness, and efficiency, lose at each step the value to the patient, and that results in patient outcomes now being about 20% survival across the board. These clinical trials, combined with registries and CQI, have the ability to improve outcomes over time. But literally, until the past 3 to 5 years, we really haven't seen a big bump in survival outcomes. And the attempts to embed those processes that are done well in our clinical trials into general practice have fallen short. However, what I'd like to tell you about is, in some pockets, some successes that we've had with implementing and using simulation and simulation techniques to really embed in clinical trials and clinical care improved outcomes. And by using a formula survival that combines medical knowledge, medical education, and implementation science, and turning those wheels, we think we can achieve perhaps a more than doubling of intact neurologic survival outcomes, particularly in in-hospital resuscitation. Let me tell you a little more about that. The National Registry of CPR, Get With the Guidelines Resuscitation, has done several assessments of the survival outcomes of in-hospital cardiac arrest across more than 400 hospitals in the United States. Before 2006, the return of spontaneous circulation was about a little less than 50%, and hospital discharge was about 18% for adults, a little higher for children. By the end of 2006 to 2010, the return of spontaneous circulation was up to 60%, with a hospital survival for children of 27%. And the most recent publication suggesting that that improvement has occurred incrementally over time is suggesting that in our hospital, with our Get With the Guidelines resuscitation review, we're now achieving 70% return of spontaneous circulation with 31% hospital discharge. But if I think back over the approach to these improvements, it really, in 1988, seemed like an insurmountable task. It seemed like Mount Everest to try to improve survival outcomes. In fact, my mentor, Arno Zaritsky, had come to the conclusion, on analysis of our data, that nobody survived if they got CPR for longer than 20 minutes or more than 2 doses of epinephrine. We analyzed the data, we published it, and we were able to convince the guidelines that really there was no treatment that would improve survival beyond this time. We had to think about the enormity of the problem. We know that more than 400,000 individuals in the United States collapse from cardiac death annually. That's 2 747 full 500-passenger airplanes crashing and burning, no survivors, every day, but it doesn't get headlines. For children, it's 2 school buses filled with 50 children each, crashing head-on, no survivors, every day. That is the enormity of the problem. And what I think we have to do is think big. We can tackle some of these big problems. For cardiac arrest, it's common. The outcomes were dismal in 1988. There were frequent and lengthy pauses. We were overventilating, interrupting CPR. Around that time, we started to get smarter, to start to implement some of the techniques and the technology that simulation education had to offer. But in climbing Mount Everest, you choose a significant target, you create a team, it really takes a village. You learn the mountain and the landscape of that mountain, and you prepare and train and persist and prepare and train and persist. You expect switchbacks, you alter the approach based on the weather, and you accept switchbacks but not defeat. You enjoy the climb, you celebrate the summit with the friends that got you there, and you climb the next mountain. What I want to relate to you is developing the culture of a high-quality resuscitation, embedding simulation science. Using the principles of rapid response teams where you assess individual risk, you recognize and judge severity of deterioration, and you take action and embed simulation. In our hospital, we chose to start at the knot in the bow tie, the cardiac arrest itself, using real-time feedback for depth and rate and the quality parameters of CPR. We added a high-risk screening and just-in-time training using bedside simulation and skill training to competence and then to excellence. And then the thing that really made the difference, that I'll show you in a moment, is the addition of performance debriefing just after event, and then with quantitative data that's fed back to the team to improve team performance. Our paradigm is this, that pre-arrest, we circle our unit and we identify those children who are at highest risk for cardiac arrest. We then roll a cart up that's outfitted with a CPR mannequin and quality of CPR feedback, and we train the bedside providers for those sickest kids who are at highest risk. If the patient arrests, during the arrest, we provide real-time feedback with that same equipment to the same providers that gives quantitative real-time feedback that allows them to gauge and improve their performance. And immediately after the arrest, we do what we'd call a CSI, code scene investigation, where we interrogate what happened. We interview those people who participated in the resuscitation. We analyze the bed qualities, the backboard qualities, and how much depth of compression was absorbed into the bed. We reconstruct that, and then we do a mini debriefing with feedback to the team that's present. And we look at the outcome of interest as the return of spontaneous circulation. But then in the days that follow, for those that have resuscitation, we go to the guidelines and we again, on a day-by-day basis, try to preempt and just-in-time train those providers to the most likely things they'll see that would support the temperature control, blood pressure management, oxygen, carbon dioxide, glucose, pH, and fluid management for those patients, the cooling protocol, et cetera, so that we can anticipate the problems just in time and provide that support and analysis of the efficacy of those interventions. And then, after the patient is discharged, we collect all the quantitative data, and in our quality improvement forum on a monthly basis, we review not just with that team, but for the whole unit, the quality parameters, the things that went well and the things that didn't. And we use as our outcome measure the survival to hospital discharge and the neurologic survival at 1 year following discharge. Of course, we overlay this on our series of simulation-based lectures, our individualized task training, and our rehearsals in situ. We have an in situ simulation room, essentially, within our ICU, where we can practice and rehearse and train. We train outside of the ICU, here in the parking lot, and also train and rehearse our simulation and communication in the trauma bays that are videotaped for both simulated events and real events, and quality improved with the identical tools that we use for our AHA courses as we use for our real events. We simulate in boot camps and bring regional partners together to simulate together to try to improve our training and exchange skills. And we have built networks, this one, the Express Network, sponsored by the Laerdal Foundation, to try to examine the debriefing techniques that would improve quality across the nation at multiple centers, doing identical simulations, pooling the videotaped results and analyzing them in a very prescripted fashion. For our real patients, we use our bedside tool to collect data and to provide the real-time visual feedback and the quantitative debriefing. For instance, at the bedside, you might see this tracing when you're doing chest compressions, and here,
compress deeper.
if you were, or it might tell you to, excuse me. Let's see if we can hear it.
Release pressure between compressions.
So a bedside coach that's automated. And when we provide feedback, we can see there are multiple channels that can show us the chest compression depth being too soft, or the force being too light, and then after a change of compressors, how that improves and how the force and depth improves. And so it can give us real feedback that allows our providers to gauge their performance. And here, there's incomplete release and prompts that are going on for that. We also reconstruct. Here's a depiction of the reconstruction using a mannequin and weights to mimic the size and shape of the patient who was in the bedside to try to subtract out the effect of the bed compression. And we download the bedside monitors to find out what the hemodynamic waveform, so we can relate the quality of the CPR parameters to the actual hemodynamic measurements in the patient. And we can plot that out and confirm the AHA guidelines that when we push more than a third of the anterior-posterior depth of the chest, that our systolic mean and diastolic blood pressures are within parameters, the targets that were set more than 50 years ago for successful resuscitation. In fact, on analysis, when our depth of compression on real patients is deep enough, according to guidelines, our odds ratio of survival of that event is 2.5 times when we don't compress deep enough. And when we look at the percentage of return of spontaneous circulation, when we push deeper than the 50 millimeters now recommended in our ICU, that we actually achieve significantly improved outcomes. But that's not all that great, because when we look at the data carefully, when we analyze the real collected data on real patients, more than a third of the time we're not meeting the American Heart Association guidelines that are evidence-based. And so we overventilate, and so we had to develop this rolling refresher program to try to address, with simulation, some of these deficiencies in our delivery of care. So we created this mobile cart, we roll it up to the bedside, and there's bedside performance of the providers to achieve competence and excellence in resuscitation at the bedside. Here's an example. Dana Niles, our research coordinator, rolling up to the bedside nurse immediately outside the room of the ICU, reviewing how to use the monitor defibrillator with the feedback, and then having a practice session, 30 to 60 seconds, providing a perfect strip. This rolling refresher technique is low-dose, high-frequency training, trying to take us from our usual paradigm in A, where we take a course and then our skills drop off below ideal or competent performance, and trying to figure out what interval to retrain in order to keep the level of performance above the line. This is a convenient sample of nurses who were trained with this technique and their evaluation. In the yellow are those that were trained more than twice with the rolling refresher program in 90 days. Those on the right side of your screen are those that were trained less frequently than 90 days. When analyzed, on your left, the time it took to achieve a perfect strip was significantly better in those that were frequently trained with low-dose, high-frequency training. They enjoyed it. We surveyed them. They felt it was good training, and they felt it improved their confidence. And that was very nice. But we continued to train, and then we measured the actual quality of performance, and we found that our percent adequate depth had markedly improved, our no-flow fraction was down, and our percent leaning was still 20%. So our depth and our no-flow fraction were very good, but that we still had a problem with leaning, more to go. But what was interesting when we analyzed the results of our real resuscitations, the prior were on mannequins, this is on real, that highly refreshed teams, when there are 2 or more members who are highly refreshed with this rolling refresher technique, that the percent of adequate depth chest compressions rose to 88% compared to 70% in those that were not recently refreshed, and the other CPR variables were not changed. Could we take this then and take it out of the ICU setting where we resuscitate frequently? We found that using this same technique, going to the wards, pre-training, there was an extremely wide range of compression rates, many of it incorrect, and by using a 2-minute training technique, we could rapidly bring them within the AHA guidelines. The same was true for the compression. And here is the percentage of performing excellent CPR, correct depth and rate, at 1 month. You can see that they got a bump, and then it fell back down. When they were re-refreshed, it went back up to 85%, down to 68%, up to 83%, and stayed above the line, looking very much like this low-dose, high-frequency refresher paradigm that you saw before as B, suggesting that we perhaps can improve our performance with this low-dose, high-frequency technique. We had to temper this now with figuring out how to achieve the depth, because some of our providers were short, some were tall, and so one of our fellows went to the metabolic lab and put on pulmonary function equipment and had a whole slew of our providers ride through and provide chest compressions on simulated CPR on mannequins with and without step stools, and demonstrated that with step stools, the depth of compression was significantly better for our providers without differences in rate or leaning, and that the time to failure of excellent CPR, time to non-compliance, was significantly longer in those that did not use the step stool. In fact, when we looked at the 50% compliance mark, it was markedly extended when a step stool was used, particularly in the shorter participants. But she additionally looked at the energy expenditure and fatigue issues and found that without a step stool, that providers fatigued faster, and also that there was an association that when they did press deeper, more than 50 millimeters depth, current recommendation, that there was 3.7 times more likely to achieve a systolic blood pressure of 100 and twice as more likely to achieve an excellent diastolic blood pressure. We further analyzed early versus late CPR and found, as you can see here in the red, that early CPR was delivered deep and fast, achieving compliance, and that over time, over a 5-minute time period, that fell off when a single rescuer was providing. But that early on, rescuers were able to maintain a 2-minute period with excellent chest compressions. So we had the real-time feedback, and we had sort of the post-arrest phase addressed, but we were still struggling to identify patients, so we made a screening tool to try to improve our identification of who needed training. And this worked. We piloted this and then implemented it and did not miss any patients. And we started to use our code scene investigation to inform our debriefings, just like we would with our simulations. And we were able to come up with checklists that we could go over with the providers prior to the arrest of those children in the ICU, and use the data captured to inform our debriefings. We were able to find segments where ventricular fibrillation was going on and there was a 20-second pause before we delivered energy, and this could be remediated when discussed with the group for the next time. And we could look at our documentation records, and we could see that they had recorded ventricular tachycardia, but when we went back and downloaded the actual waveforms, we were able to demonstrate that this is indeed what ventricular tachycardia looks like, and what they were calling VTAC was actually CPR artifact. And we could then display that for the whole team so that they could learn from that and inform their practice. And we could also show that those that were distracted during CPR, here's feedback saying push a little deeper every 5 seconds. When we went back and reviewed the audio tape, the chest compressor would concentrate when they heard the audio prompt for about 5 seconds on excellent chest compressions, and then would become distracted looking around trying to coach others on to breathe a little slower, to do some other things. And so we found out that the intensivist's attention span was a bit short. Now, others have suggested that debriefing can improve outcomes. Dana Edelson has been able to demonstrate that debriefing of the specific resuscitation team has been quite effective in improving survival outcomes in adults, but has not significantly actually improved their resuscitation quality parameters. We are, of course, trying to become like a pit stop where our team performs to perfection. And with the addition of these debriefing episodes, this is not yet published data, but what I want to share with you today is that the recent analysis last week of our last 70 resuscitations in the ICU revealed that compared to an 18-month pre-debrief period, our 18-month post-debrief period was able to demonstrate that for depth, rate, CPR fraction, and leaning all had significant improvements from previous pretty good values. And importantly, during the debriefing period, our excellent CPR, where all 4 parameters of CPR were correct, went from 29% to 61% of epochs, 5.6 times better, and our return of spontaneous circulation improved from 70 to 80%, not significant. But our survival to hospital discharge improved from 31% to 51% over that period, and our intact neurologic survival from 26% to 49%, a doubling of intact neurologic survival from cardiac arrest in the ICU. And if you remember back to our predictions of what potentially simulation education techniques could do, we had predicted that we could get at best about 48%, and now we are approximately 49%. So we have done a number of things that might improve the quality in that specific unit to the best of our ability. But is that enough? Well, we think the future is coming, and we think that we should now be embedding training into care, that training is a part of care. It is no longer extra and on top of care. It is really essential to the care. And we have to really interface our education with our care. What's on the immediate horizon? We are trying now to embed simulation training and link it to patient care outcomes. In other words, we can perform rolling refreshers at the bedside. We can have people sign up in our simulation room or our simulation center to receive resuscitation training, or we can evaluate their real care on real patients in our ICU. And all 3 of those events should qualify with proper debriefing to be saved and banked for their training records. Give them credit for the ACLS course during their actual practice. In fact, we have a rolling refresher BLS curriculum where we can track whether you do real CPR, simulated CPR, rolling refresher. And we have a curriculum where each month you get an additional training according to the Heart Association guidelines that supplements that, so that by the end of the year, you have achieved your resuscitation training at the bedside. You don't have to take 4 or 8 hours off and go to a center to train. We also have evaluated in other areas the AHA guidelines and how we perform, and we don't do that well when we are not frequently trained. 92% outside of the ICU had a depth less than 50 millimeters, 6% had perfect CPR, and 75% of the healthcare practitioners outside of our ICU had the wrong hand position when they initially started chest compressions. We have a long way to go. In fact, Akira Nishisaki and some of the young investigators from our hospital are embarking on what we're calling a PALS on Demand program, where first they're taking the PALS course and breaking it up into small segments, small chunks that can be trained in a mock code every month, and then adding up those experiences so that it totals the course by the end of the year, sort of a PALS distributed model. But then they're evolving to a PALS a la carte, where selected practitioners can pull from the shelf the mock code or the experience that they feel they need or want based on the patient that they're caring for that day, and trying to evolve to a PALS on demand where essentially we'll capture their real experience at the bedside resuscitating a child and debrief and bank that experience for all of the providers. So in other words, you could qualify by doing a rolling refresher, a simulation, or an actual patient care event, and it would fulfill your Heart Association requirements, but also your hospital requirements. That could be for chest compressions, but it's beyond chest compressions, because we could do it for septic shock, for difficult airway, for anaphylaxis, for pneumothorax, for trauma, for any of our protocols that we have. We could develop systems in order to link training and performance. Beyond that, we know that babies, approximately 3 to 6% of babies require basic resuscitation, bag mask ventilation at birth, and worldwide that's more than 6 million babies. So we are translating this to our neonatal ICU, pre-delivery, assessing risk, doing huddles and rolling refreshers for bag mask ventilation, assessment at time of birth, and for babies who require it, recording the outcomes of bag mask ventilation in our delivery rooms and delivery suites. And then post-delivery, having a huddle, a debrief, and then a quantitative and weekly and monthly feedback in an attempt to improve the performance in those arenas. We've translated that to central lines. Our nursing staff now does dress rehearsals for central line dressing changes to try to decrease the rate of central line associated bloodstream infection. And Akira and his crew have done this for tracheal intubation in our ICU. And of note, the simulation intervention that we devised to improve resident performance for tracheal intubation, where Akira came in every day from 6:30 to 7 every morning to train the on-call resident using simulation before they took their 24-hour shift, now 16-hour shift. They did not improve their performance because they didn't have enough time to make the learning curve up to excellent intubation technique. And so we no longer are doing that. This was a simulation intervention where we demonstrated that the high-fidelity simulation that he was doing was not resulting in a patient outcome that was important. And thus we deep-sixed or stopped doing that training intervention that was not effective. So we have to, that's a setback or a switchback that we have to pay attention to. So where are we going in the future? We see that networks, such as the INSPIRE Network, International Network for Simulation-Based Pediatric Innovation, Research, and Education, is the wave of the future. No hospital, mine included, is large enough or big enough to really be able to study what we need to know and to be able to generate tools that are generalizable unless we use our networks and friends. We need technology improvements. This is our ECMO circuit at the moment. Can you find the baby or the providers in the picture? There's the baby. We need to shrink this down. We need to make it simple and usable and employ our human factors. Perhaps our ICUs need to be more like our cars, our smart cars, with OnStar Online. If you drive a GM car, you could subscribe to OnStar where they're constantly surveilling your engine, your performance, your oil level, your tire inflation, and if they detect a deviation or a problem, they call you. If you're in a car accident, they can contact you, they can geolocate you, they can send 911, and they can track the outcomes of that and the time of arrival. So perhaps we need to be more like the air traffic controllers. Perhaps the instant replay that we see in our sports stadiums with instant replay and refereeing. In moving forward, I think we're going to need to learn how to better embed training and real care. We're going to need to learn how to use social media. How do our cell phones interact? How can we learn from experiences and grade those experiences and improve the care as we move forward? Our sim ecosystems are growing. We have the capability of moving internationally. And we need to simplify our tools because we are learning more and more that as we get more and more complex, that we will need to serve the needs of the world. Our tools are very complex, and as we simplify them and bring them to developing countries, we will find that we have more and more success. So I'm going to close, I think, with a caveat, with a little call out that many, many years ago, we thought that resuscitation was impossible. We were resigned to the fact that we would not have good outcomes. And we really didn't have a system to move forward. I think that we are moving together in the right direction, and that it's really the simulation generation, the next simulation generation, you and us, that will move us forward. Thank you.